Well, I'm Keith Smith, anesthesiologist in private practice since 1990, and founded the Surgery Center of Oklahoma with another anesthesiologist, Dr. Steve Lantier. Thank you. And I won't go too much into the history of our organization because I think many of you in the room are very familiar with what we've done. I'll leapfrog to 10 years ago now. It doesn't seem like it could be 10 years ago. We launched a website that had all of the prices for the procedures that we perform online. And the only changes that we've made since that time is to add procedures and lower prices. So I want to congratulate everyone in here on this conference. The size of the conference, I understand, is double what it was last year, and I believe last year was double what it was the year before. At the Free Market Medical Association, which Jay and I have co-founded in an attempt to bring buyers and sellers of medical services together, keeping the number of intermediaries absent or to a minimum, only including those who facilitate that purchase exchange. We've had a similar trajectory. We've doubled every year since we started. This is our fifth year, and our annual conference will be in Dallas this April. You would all be welcome to attend. Dr. Ron Paul will be our keynote speaker. I really was surprised. I asked him and he said yes, he was happy to do it. He's a big fan of everything everyone in this room is doing. He's a big fan of yours, Lee, you and Josh, very aware. So congratulations on the size of the conference. This is very, very impressive. And it's truly a nightmare for all of the thugs that are involved in this industry. It really is. Well, it is. The healthcare industry, as any of you know, that got really close to burnout and felt like your back was against the wall. This is a real oasis, but also know this is a real nightmare for the bad guys in the industry. So congratulations to you all. So I was asked to talk about the dysfunction of hospital care, and I'm gonna kind of fork off and go two directions. One is a description of the current dysfunction and how it works, and how our putting prices online 10 years ago revealed to us really how the scam and how the cartel works. And I refer to the cartel when I say that. I'm talking about the big hospital systems colluding with the big insurance companies, with Uncle Sam driving the getaway car. So the three goons involved in this cartel are thus described. I also like to say that the only difference between a Mexican drug cartel and the health cartel in this country is the Mexican drug cartel actually does what it says and delivers a product. The second part of this is the more involved part, and it is the true reason for hospital care dysfunction. And it might surprise many of you for me to say the real reason the hospital care and dysfunction in the marketplace is downstream and the result of everyone in this room not owning the hospitals where your patients receive their care. And I see that as part two, not terribly far downstream of this movement, where everyone in the room takes control of their practice. But it's high time we get back to the day when the primary care doctors owned the hospitals where their patients received their care. That is, after all, how almost every hospital in the United States started. It's a throwback, but at that point you then are a medical and a financial advocate for your patients. I'm going to come back to that. So I'll go through the dysfunction and how it works, as we've discovered by just putting our prices online. And some of you have heard this before, but I'll go through this for the benefit of those of you that have not. I like to use the example of the $100 aspirin and its journey through the cesspool of this healthcare system so that you can understand really how this works. So a hospital generates a gigantic hospital bill, and let's say they bill $100 for an aspirin. The insurance company rides in and discounts that $100 and pays $5. The hospital claims they lost $95, don't you know? We all know they paid a penny for the aspirin. But the hospital uses this claimed loss of $95 as care for which they were not compensated, and it also justifies the fiction of their not-for-profit status. You think, okay, this is gross, but it gets worse. The insurance company, you think, well, how does this work? How is this good for the insurance company? Well, insurance companies, it turns out, make some money by collecting premiums and paying claims, and to the extent that the premiums collected are more than the claims paid, they have some profit. But there is another source of profit, and it is this discount from $100 to $5 for the aspirin. Let's make this more fun. Let's make it a $100,000 aspirin, which is basically what a lot of hospitals charge for a knee replacement that's $15,499 at my facility. So, yeah, $100,000 bill, insurance pays $20,000. Hospital says we lost $80,000, and that justifies the fiction of their not-for-profit status. The hospital then takes that $80,000 loss, throws it into a slop jar, ships it off to Washington, D.C., where they receive a kickback called this disproportionate share hospital payment or uncompensated care payment. They receive a kickback to the extent that they claim these losses. So it's like a reverse Enron, where Enron bolstered their profits by over-exaggerating earnings. Hospitals make more money by exaggerating their losses. So hospitals claim they lost all this money when it's simply a fictional accounting exercise. And then they get paid by the federal government to the extent that they claim these losses. Now let's get back to the insurance company. The insurance company paid $20,000 for this $100,000 bill. Then they ride into the employer group. And this is why it's important. Phil Eskew's talk was fabulous. I don't know if he's in the room. It's important for you guys to understand self-funding. The insurance company then rides into the employer group and says, listen, they're on their white horse. We have this $100,000 bill and we discounted it down to $20,000. We saved you $80,000. Now forget that all this is pre-negotiated between the hospital and the insurance company. But the insurance company then collects a commission from the employer to the extent that these savings were achieved. So if you think through that, you mathematicians in the room, the insurance company would rather have received a $200,000 bill. In fact, hospital administrators, they shock some of you that I actually know some and they speak to me, but hospital administrators have told me it's not uncommon for an insurance carrier to ask the hospital to double a charge, because that allows them to maximize their profit on this claims repricing exercise. So that is how the current dysfunction works. And the reason I know this is when we put our prices online, knee arthroscopy is $3,740, gallbladders $5,865. All the prices are all inclusive. No insurance carrier wanted to work with us, and it did not make sense. I mean, our facility is known for its quality. It's darn sure known for its price. And so as a value, why would an insurance carrier not want to work with the Surgery Center of Oklahoma or anybody else that posts their prices for that matter? And the reason is they forego this skimming of the claim. They forego this opportunity to sell a discount. So that is, I think, one of the reasons I was invited was to share that part of the answer. More importantly, I believe the reason the system is so dysfunctional as I said before, is the doctors should own all of the hospitals, all of them. And physician ownership in itself is not anything special. But physician ownership coupled with price transparency and the ownership of the primary care doctors is unbeatable. That is the system that actually was available until the federal government inflicted something called Hill-Burton on us, so these government hospitals metastasized all over the country, and they were not satisfied with billing patients. And so I believe that's why we wound up with Medicare and Medicaid, because these government hospitals wanted to plug directly into the taxpayer trough and not collect from patients. And then it was game on. Prices went through the roof. Patients would come in and say, I've got this horrendous hospital bill, to the physician who admitted them to the hospital. And at that point, the physician could say, that's the hospital. I can't really do anything about that. All of that goes away when the physicians own the hospitals. But as future owners of hospitals, that is how I'm going to wrap this up, because I think everyone in this room will have the opportunity to do that. And also tell people this is the cure for the manpower shortage in rural America. I know physicians in urban areas that would leave and go to a rural area if the opportunity to own the hospital was there. So, as an owner of a rural hospital, I think you need to understand self-funding. You need to understand the concept of self-insurance. Self-insurance, I hope this doesn't bore you, self-insurance is where an employer tells Blue Cross to take a hike. United, take a hike. We are going to assume the risk, and we are going to pay for our employees' care out of operational revenue. I'm self-funded at the Surgery Center of Oklahoma with 43 employees. So this is not just a game for huge companies. So we have 43 employees, and we're self-funded, and we've saved millions of dollars since making this decision about 16 years ago. So I buy all of the care that the employees at the Surgery Center of Oklahoma receive. But I've given someone else the checkbook because I have a full-time anesthesia practice and I don't have time to write all those checks or evaluate those bills. I happen to give my checkbook to Jay Kempton. Jay Kempton is one of many, although he's awesome, he is one of many third-party administrators that administer these claims. So Jay basically has the Surgery Center of Oklahoma's checkbook, and he writes the checks that are authorized for this care. Everyone in here needs to understand this because of the following. Half of all of the medical bills in the United States are paid by Uncle Sam. We live in a socialized healthcare system. Half of it is socialized because the government pays for it. There is no sticker shock. And when the government says we actually care how much healthcare costs, what bunk. They pay hospital-employed doctors double what they pay you guys for the same service. So give me a break. So when you think about half of the care being socialized, think about what is the other half. Well, the other half is private. Of that other half, 80% is self-funded. 80% of the other half is paid for by self-funded companies. That is the mother lode for your DPC practice, and that is also the mother lode buyer, the buyer that actually has sticker shock, the one that buys from you that, like for me, Jay's other clients, they don't want to buy a $30,000 hernia when they can buy a $3,000 hernia at my place that I would argue is better. So they have sticker shock and they are looking for value. They're looking for you. So I would encourage you to understand self-funding, because that is where a huge potential buyer And it feels very much like you're dealing with the patient directly, even though the employer is there. And that's something I think everyone should understand. Understand, though, there are some obstacles that you'll encounter as you begin to explore self-funding. Some of you may be very enterprising and entrepreneurial, and you think, well, I know the director of human resources at Company X down the street that is self-funded. Don't waste your time. Never talk to HR. They have a language of their own. I don't know anyone that understands it. I don't think they understand it. And remember, HR exists because employers don't want to be in the healthcare business. And they have an entire department to make sure they never have to hear about any of that stuff. HR also has a relationship with a broker or a consultant who probably is on the take from one of the carriers, and they are not going to hear what you have to say. If you want to approach a self-funded company to gather their business, you must be talking to the decision makers in the company. They will then instruct HR about how things are going to go going forward. I know I'm being very harsh, so you will hear this message. There actually are some HR exceptions to what I've said, but they are very, very unusual. Your default should be, talking to HR is a waste of time. When you're playing golf with the CEO or CFO of some big self-funded company, understand they will look at you as a dog looks at a tick, because this industry is disgusting and physicians are not seen as part of the solution. Physicians, largely by employers, are seen as a part of the problem. So you will encounter an initial reluctance to actually believe what you are saying. But once you show them and convince them that what you have in mind is for real, you will have a loyal friend for life. One of the other points I want to make is that there are some self-funded employers you do not want to work with. There are some self-funded employers that are self-funded so that they can, like the most vicious HMO out there, deny care to their employees and pad their bottom line. I don't work with those kind of people. I'm aware of two, and I won't name any names, but there is one employer I know of, a large employer, that viciously denies care to the beneficiaries of the self-funded plan, only to very conspicuously and flamboyantly hand out other benefits that the employees have their eye on as a distraction, not knowing that this is a complete distraction and is completely funded with funds derived from the denial of care to those employees. It's a very large employer, and it's not anyone that I would ever entertain working with. There's another employer that picks certain facilities and designates them as the only facility where, say, a spine procedure could be performed. This one employer I know of has told this one hospital, we've designated you and you'll be our spine surgery provider, but only on the condition that half of the patients that meet the criteria for surgery are denied. Those are the kind of self-funded employers you do not want to work with. You want to work with self-funded employers where dealing with the patient feels like you really are dealing with the patient. Because after all, a self-funded plan consists of funds that actually belong to the employees. It is under the administration and supervision of an administrator and an employer, but that money actually belongs to the employee. So if you're dealing with an employee who works for an employer and it doesn't feel like a cash transaction, and it won't feel exactly like a cash transaction, but if it doesn't feel really close and you smell a rat, there may be a rat. There may be a rat because they're out there. One of the reasons I want to encourage everyone in this room, in this organization, to proceed and to continue to battle, and this is a battle. Somebody in LinkedIn got on to me the other day because I was using war terms. I was, welcome to the revolution, welcome to the resistance. And anybody in this room that has dealt with a hospital administrator or has had your back against the wall or facing burnout, this is a war. And all you've got to do is go to Canada to look what losing the war looks like. I mean, so it is a war, and I want to encourage all of you to maintain your resolve. One of the most, and I truly believe DPC is the most disruptive part of the free market revolution in this country, and here's why. A hospital-employed primary care doctor, we can all feel sorry for him a little bit, but not much, but a hospital-employed primary care doctor is going to refer his patients to a hospital-employed surgeon, whether he's any good or not. And in the meantime, he's going to try to gin up his RVUs to maintain, some appearance that having hired him is a good idea by this hospital. So when you see the patient, you are their medical advocate, you're also their financial advocate. And when a patient sees a DPC doctor, someone who's not employed by a hospital, going up the sausage tube of trying to maximize revenue is disrupted, and it just doesn't happen. And that is why I believe in this war, the tip of the spear is 3 letters, and it's DPC. So thank you all for everything you do. Thanks for having me.